All right, so it's 8 o'clock, and we're gonna get started. Today is our fifth edition of the virtual curriculum for UVA Orthopedics. I'm Winston Gwathmey, Program Director. Keith Bachman's here as well, the Associate Program Director. Like I said, each time we're gonna showcase a different division, and tonight we'll be showcasing our foot and ankle division. So Venkat Perumal is one of our foot and ankle faculty. His two partners are Dr. Chewett Cooper and Dr. Joe Park. Both of whom are texting me right now, and I'm not sure if their power is going to come back on or not. So hopefully they'll get their power back on. But if not,
I'm here.
We'll still.
I'm here.
Here, Dr. Park showed up. So
I'm in my office. Yep.
So you lost power out there at your house too?
Yeah. I lost internet. We have a generator.
What a mess. All right. Well, tell you what, I'm going to stop talking and let Venkat go, but after Venkat talks, we're going to have a couple of cases that Dr. Burgess, who's our PGY-3 on the foot and ankle service, is going to present, and we'll have some discussion with our faculty. And then Baris Yildirim is a chief resident down in Roanoke, who is going to talk about the Roanoke rotation. I think it's really important that we talk about our experience in Roanoke, because I think it's a really strong part of our program. And so we have 4 residents down there currently, and I think all of them will be on the call so we can answer some questions. And if there's time at the end, Dr. Bachman and myself will be available for sort of any questions you might have as far as curriculum and other stuff, okay? So without further ado, Dr. Perumal, the floor is yours.
All right. Thanks, Winston. Thanks for everybody who's taken time to, join us today for this talk. We will talk about tibialis posterior tendon dysfunction and flat foot. So this is our foot and ankle division. So it's myself, Dr. Chewett Cooper, and Joseph Park. We three are, the foot and ankle division. Talking about tibialis posterior tendon, tibialis posterior tendon is one of the common causes of adult acquired flat foot deformity. Tibialis posterior tendon fails, we'll get mostly a flat foot deformity. There are other causes as well of the to cause flat foot deformity as well, but most common is the tibialis posterior tendon insufficiency. Let's go through the anatomy of the tibialis posterior tendon first. This is the anatomy of the posterior aspect of the leg. This shows where the origin of the muscle, tibialis posterior muscle. It originates from the posterior aspect of the tibia, interosseous membrane, as well as the fibula. And if you see the medial aspect of the ankle, the tibialis posterior tendon comes all the way down, just very close to the medial malleoli, and gets attached to the navicular bone right there. Right next to that is the flexor digitorum long FDL, as well as, and then the neurovascular structures, and then the FHL tendon. So it's very important to know the anatomy on the medial aspect of the ankle when you treat this tibialis posterior tendon insufficiency in flat foot. So talking about the muscle itself, like tibialis posterior muscle, like I talked about, like originates from the posterior fibula, tibia, as well as the interosseous membrane. It is innervated by the tibialis posterior nerve. Tendon gets attached to it goes posterior to the medial malleoli, comes down towards the navicular tuberosity, and it has an anterior limb, middle limb, and the posterior limb. Anterior limb is the mostly strongest one we usually talk about. It's attached to the navicular tuberosity. The other limb, middle limb, as well as the posterior limb, goes on the plantar aspect and supports the arch as well. The blood supply of this tendon as well as the muscle is the posterior tibial artery. There is a watershed area of this tendon, which is from the medial malleoli down towards the navicular, which is roughly about 2 to 6 centimeters, has very less blood supply to the tendon. That is where the tendon usually fails. Most of the tendon in the foot usually fails in the watershed area. The tendons, in the medial side as well as the lateral aspect of the ankle, most of the tendon around the foot as well as the ankle, they have a watershed area where the tendon usually fails, ruptures. Talking about the epidemiology, who is the common, who gets this tibialis posterior tendon insufficiency? Tibialis posterior tendon problem is mostly the women, and usually the 5th and 6th decade. Obesity is one of the main reasons for this tibialis posterior tendon insufficiency. Other causes as well causes are inflammatory disease of the joints as well. The mechanism in which the tibialis posterior tendon fails, we do not know why exactly. We do not know why it fails, but it's usually multifactorial, meaning that it could be the way the trauma, the repeated stress can cause the tibialis posterior tendon to fail. What happens is, when the tibialis posterior tendon gets inflamed, it causes tenosynovitis, inflammation, and then what happens is there's a little bit scarring around the tendon, causing incompetent of this tendon, causing tendon to lack excursion, meaning that it does not, there's no excursion of the tendon, and then the tendon fails to support the arch, and then the arch fails, and then the foot goes into valgus. So that is the main pathoanatomy, how the tibialis posterior tendon dysfunction causes flat foot. Little bit about the biomechanics of the tendon. So the tibialis posterior tendon lies posterior to the axis of the tibio-talar joint, and it comes down posterior to the medial malleoli and on the medial aspect of the subtalar joint. If you look into the axis of the tibialis posterior tendon, it is usually posterior to the ankle joint and medial to the subtalar joint. It is a powerful inverter of the hind foot. So that is the reason, inversion is mainly by this tibialis posterior tendon. So the main function of tibialis posterior tendon in the gait is, it locks the transverse tarsal joint when there's a push off, so that the heel can go above the floor when they have a toe off or push off gait phase of the gait. This is anatomy of the medial aspect of the ankle, showing the tibialis posterior tendon. It comes across posterior to the ankle and medial to the subtalar joint. It gets attached to the navicular tuberosity. So, what are the symptoms of tibialis posterior tendon insufficiency and pain? Usually, it's mostly the pain on the medial aspect of the ankle, medial aspect of the foot, which is a common symptom of this tibialis posterior tendon pathology. When the tendon fails, there's a progressive loss of arch, and then the heel goes into valgus. Sometimes you see patients with gross valgus deformity of the heel. They have lateral ankle pain as well. That's from the subfibular impingement. Physical examination of the patient. When you examine the patient, they have collapse of the medial longitudinal arch, hindfoot valgus deformity, and tenderness over the tibialis posterior tendon just behind the medial malleoli. If you look at this with this picture, this is from the back, showing the hindfoot valgus. You see this is the long axis of the leg, and then it goes to the long axis of the calcaneus. This is gross valgus. You see the foot is complete in valgus and abduction, where you can see the too many toes. So it's called that as too many toes sign. Often with this valgus foot, there is always a equinus contracture or contracture of the Achilles tendon. That's because the heel goes into valgus, and then the long axis of the Achilles tendon gets contract. So this is a close a picture of the hindfoot valgus. If you see this foot, it's in the gross valgus deformity. You could see the too many toes sign there, showing the valgus of the heel, as well as abduction of the foot, so that most of the toes are seen from behind. Usually, we don't see more than one toe. So if you see, you can almost see almost all 4 toes in the lateral aspect. So once we clinically examine, we do the imaging. Mostly it's X-ray, AP lateral of the foot, and we usually take the hindfoot alignment as well, which is called the Schwarzman view. That is the view. This is the view right there in the X-ray, long axis of the tibia and long axis of the calcaneus. We rarely need an MRI. MRI is usually to see if there's any tendon rupture, the tibialis posterior tendon. So MRI is not a common not commonly necessary to diagnose this flat foot. So this is the AP of the foot. A couple of things what we see in the AP of the foot is there is an increased talonavicular uncoverage, meaning that this is the talus and this is the navicular. Since there is an abduction of the foot going out, there is uncovering of the talus right there. And if you see the long axis of the talus going all the way straight and long axis of the metatarsal, it's not the straight angle as well. So this is leave alone this the calculation. There's multiple ways to calculate the uncovering of the talus. But if you see on your left, there's good coverage of the talus. That's the navicular right there. Good coverage of the talus. On your right side, you see there is uncoverage of the talus. That's because of the abduction of the foot. So a couple things. So if you see this X-ray there, there's, this is the normal foot. This is the flat foot. The calcaneal pitch is lost, meaning that, the angle A is completely lost. And what happens is, if you draw a line along the long axis of the talus to long axis of the first metatarsal, it's pretty much straight, parallel, or the one line. But here, it forms an angle. I'll show you in the next X-ray. So typically, in a weight-bearing X-ray, we usually see there's an increased talar first metatarsal angle, which is called the Mary's angle, decreased calcaneal pitch, decreased medial cuneiform floor height, and you could see arthritis of the ankle, subtalar joint, and other joints as well. So this is what I was talking about, the lateral X-ray. This is the long axis of draw a line along the long axis of the talus, along the long axis of the first metatarsal. It's a straight line. And if you see here where the medial arch it's collapsed, it forms an angle. So typically what we say is, like any angle, a convex angle of more than 4 degrees it's called a plus planus or a flat foot deformity. Calcaneal pitch normally is about 20 degrees. That's a normal calcaneal pitch right there. This is the inferior aspect of the calcaneus long axis right there. And the line along the floor forms an angle right there. So it's usually roughly about 20 degrees. And if you see in this, it's about 12 degrees in a flat foot. So the calcaneal pitch decreases as well. So what are the classification, of the tibialis posterior tendon dysfunction and flat foot? So it goes from stage 1 to stage 4. Stage 1 is the mild one, and stage 4 is the worst. Stage 1, what we call as, it's just inflammation of the tendon. There is no deformity at all. That is at stage 1. Stage 2, there is deformity of the foot, both forefoot as well as hindfoot deformity, but the deformity is corrected. You can correct the deformity, meaning there's no arthritis, there's no fixed deformity. Stage 3, if there is a arthritis and the deformity is fixed, it's both, foot deformity as well as the hindfoot deformity. It's stage 3. And stage 4, where the deltoid ligament fails and the ankle goes into valgus as well. So it's basically, these deformities these stages are very important to know, so that we can treat according to the stage of the deformity. So stage 1, just inflammation of the tendon. They have usually pain, no deformity. They should be able to do a single leg or toe raise. Stage 2, there is a flat foot deformity. Hindfoot is in valgus, but you can correct the deformity. Stage 3, you have flat foot deformity, heel is in valgus, but you cannot correct. In an X-ray, there is a subtalar arthritis, a TN joint arthritis. Stage 4, the valgus is so bad that the deltoid ligament fails, and there is a valgus deformity of the talus, so that the ankle joint opens to the medial side. So the stages are very important to come to a first diagnosis as well as the treatment option as well. So once there is a deformity in the hind foot as well as the medial arch, we need to know whether this is a deformity flexible or fixed, so that we can differentiate between stage 2 and stage 3 tibialis posterior tendon dysfunction. Always, in a flat foot deformity, don't forget to get an ankle X-ray to see how the ankle mortise is, right? in a stage 4, where the heel valgus is so bad, as I told you before, the deltoid ligaments on the medial aspect, gives out, and then the ankle goes into valgus. So we can treat this non-operatively as well as operatively. Usually, stage 1, stage 2, we can treat it as treat non-operative. The main thing is you can immobilize the ankle with a walking boot for roughly about 2 to 3 months. There are orthotics available to support the medial arch as well as the medial heel post, so that the heel valgus can accommodate. Period. So we can first start with stage 1 and stage 2. We can always treat with non-operatively with the walking boot or the inserts for the heel valgus. If you come to stage 3, stage 2, 3, and 4, if you cannot operate on the patient, the non-operative options are usually it's an AFO, which calls an Arizona brace. So you see the picture of the Arizona brace here. It shows, is this an AFO custom-made brace, where take the mold out of the foot and ankle and then make the brace. So this is a very rigid brace, and if stage 2 to stage 4, if the candidate is not an operative candidate, this is the brace we go with. So what is the operative treatment if non-operative options fail? The operative options are stage 1 with stenosynovectomy. Usually we don't see this stage. It's very rare to see just a tenosynovitis stage 1. Stage 2, if there's a flat foot deformity which is flexible, we can do osteotomies, tendon transfer to correct the deformity. Stage 3, where there is arthritis of the subtalar joint and the TN joint. In stage 3, it's always a triple arthrodesis. You have to fuse the subtalar joint, TN joint, as well as CC joint. And in stage 4, where the ankle is involved, we have to do a tibio-talocalcaneal arthrodesis. Or now it's a little bit, we're getting into a deltoid reconstruction, and eventually either a triple or a total ankle replacement, but that's a little bit controversial. We're not going to get into that right now. So stage 2, talking about stage 2, what's the deformity? You have a heel hindfoot valgus. So we do a medial displacement calcaneal osteotomy. What that is we do an osteotomy of the calcaneus, switch the heel medially. So you displace the heel medially to correct the hindfoot valgus. And if there's a forefoot abduction, we do a lateral column lengthening to correct the forefoot abduction. And always there's an equinus contracture. Either you do a Achilles tendon lengthening or gastrocnemius recession, depending upon where the contracture is. And if there's a forefoot supination or a varus deformity, we always do a Cartan osteotomy. And if the tibialis posterior tendon deficiency is bad, that the tendon is so bad, you can always augment that with the FDL tendon transfer. So depending upon what the deformity is, we do this surgery. But typically it's a combo of everything. So hindfoot valgus, MDCO, lateral column lengthening, forefoot abduction, equinus deformity, either the Achilles tendon lengthening or the striate procedure, Cartan osteotomy for forefoot supination, and tendon transfer for tendon deficient. Stage 3, when it comes to stage 3, where there's always subtalar arthritis, TN joint arthritis, or CC joint arthritis, it's always a triple arthrodesis. We fuse all 3 joints. So stage 3, triple, that's how we know, we usually remember 3. Stage 3, triple, 3. So you fuse all 3 joints. Sometimes, in stage 2 with obese patient with rheumatoid arthritis, where we suspect, arthritis, but still they're asymptomatic, we still, we don't go with a triple arthrodesis. Just going over with, again, with this operative management, stage 1, we don't do anything, it's just mostly orthotic. Stage 2, depending upon what the deformity is, we can correct the hindfoot with a calcaneal osteotomy, forefoot correction with a lateral column lengthening. And off late, we are seeing more and more emphasis on the spring ligament repair. Stage 3, triple arthrodesis. Stage 4, when it comes to stage 4, we have to address the ankle. It's either a talar calcaneal arthrodesis, or we can do a deltoid reconstruction and triple, as well as the ankle replacement. That's it from me.
Thanks, Venkat. That was awesome. So that's the foot and ankle division. So Dr. Cooper, Dr. Perumal, and Dr. Park, the resident will rotate on foot and ankle during their PGY-3 year. Really a great rotation because just one resident rotates at a time, so they have a lot of autonomy with those attendings, and so it ends up being a lot of fun. So I think Dr. Burgess, who's our current PGY-3 on foot and ankle, has cases. James, you out there somewhere?
I am.
Do you want to share your screen?
Yes. Dr. Perumal, can you stop sharing?
Yep.
Yeah, I can stop him.
Okay.
Let's see if I can figure this out. All right, try now. Go for it. Hey, everybody. Mail. Yeah, so we certainly see a lot of flat foot, and so I think it's important. And part of the reason why I want to highlight these different divisions is that, in order to be a practicing orthopedic surgeon, you got to be able to manage a multitude of different kind of conditions, regardless of what your subspecialty is. And so flat foot is pretty ubiquitous, especially in the middle-aged female. And so being able to identify, evaluate it, and manage it is going to be really important. So your screen is black, James.
Okay. That's problematic. Let me see what I can do about that.
You got to describe it. You have to go old school, the way we used to have to describe those things.
Okay. PowerPoint.
Multi-vegan. There you go.
Oh, yeah. There we go.
Cooking.
Shout out to Matt Deasy.
So if I could have Dr. Park, if you're available, and Dr. Cooper, if you're out there, and Dr. Perumal, just be available to kind of go through this case with Dr. Burgess. That'd be okay.
Okay.
Being free.
Okay. All right. Sorry, let me.
James, we lost you again.
I know.
And Baris, after this, you're up to talk about Roanoke, okay? Awesome. Go for it, James.
Okay. All right. So case 1, 40-year-old female. She's a healthy vegan. She's gainfully employed, and she likes to go up in the park on the weekend, go on long hikes and stuff. Pretty normal BMI, 26. Came in with chief complaint was progressive pain, medial aspect of her ankle. She tried home measures, taking some ibuprofen, wrapping it up with an ACE wrap. When it really flared up, she'd take a week or two off, and now having to limit her activity, not really able to hike the same distances or run. On exam, the thing about the foot and ankle exam, it's a pretty quick exam. It's pretty thorough. You can get standardized and start to get a feel for normal pretty quickly in the clinic. Observe her to have a flat foot as soon as we go in the room. Like Dr. Perumal showed the picture from looking behind the patient, we could appreciate about 7 degrees of heel valgus, noticeable valgus there. And then pain with resisted inversion while the foot's in plantar flexion. So that's important. I also have tibialis anterior, which can work concomitantly with the posterior tibial tendon. So we try and isolate that with the foot and a little bit of plantar flexion. So no weakness, but that reproduces the pain she's having.
So James, why is pain and resisted inversion important?
Yeah, so that's testing the posterior tibial tendon. And so we want to isolate that from tibialis anterior.
And that's why you put it in plantar flexion?
Yes. So when it's in plantar flexion, it isolates the posterior tib. So, most orthopedic patients, we assess their chief complaint. We get them some x-rays. See here, Dr. Perumal discussed some of the radiographic measurements. We see some talonavicular uncoverage, no significant arthritis, nothing stands out at you here, but looking at some of the measurements, she's got generally a flat foot, so an increase in Meares angle and a decrease in the calcaneal pitch.
So I always learn that when the first metatarsal and the fifth metatarsal overlap, or if there's that much overlap, that's going to be a flat foot situation too. Is it accurate, or am I just?
I think that's an easy way to look at it as well. Yeah. So
I was a sports guy looking at it.
So at this point,
see how much. I was just saying, see how much above the base of the fifth metatarsal or the cuboid that first metatarsal and medial cuneiform are compared to the other side also.
Awesome.
So we got a pretty high functioning female in her 40s with some pain, but the posterior tibial tendon, it is functioning, but kind of localizes on exam, x-ray and clinical exam with a flat foot and a little bit of hindfoot valgus. Anyone got any ideas of the initial treatment? We always like to talk about non-operative options first. It's very easy.
Do we know what stage this is? Have we decided what stage it is?
We would volunteer. We'd assess this as a stage 2 flat foot. So
James, what is the power of tibialis posterior tendon on this? You didn't mention the power. What is the power? Is it
so the 4 out of 5, good, pretty good strength, but painful. Kind of reproduces the pain up across the ankle.
okay?
So looking at operative versus non-operative managements here, we always like to let patients know their options. It's kind of easy sometimes to focus on the surgeries we know how to do, but that's not always the best first option. So she was immobilized in a fixed ankle walker, and then gradually resumed weight bearing with some custom orthotics like Dr. Perumal talked about, with some medial heel posting there, help to correct that hindfoot valgus. It'll offload the posterior tibial tendon first. For some people, this gives a durable result, and they don't, they can go back to most of their normal activities with a couple pairs of orthotics in their athletic and hiking boots. She came back, pain had returned, so she, moved on to surgical options. Dr. Perumal talked about some surgical options. Again, we have a whole toolkit of things we know how to do. We know how to do calcaneal osteotomies. We can debride the tendon. If the tendon's weak, we can consider transferring something like the FDL. Lateral column lengthening will help with patelonavicular coverage. Spring ligament repair is becoming, the involvement of the spring ligament in these acquired flat foot deformities is becoming more understood, and repair or augmentation is more of an option. And then the cotton osteotomy, or that dorsal opening wedge osteotomy. That's not to say that we do all of these procedures in all patients, because we don't. It's just as we assess the various components of each patient, these are things we might consider.
So James, go back to the slide, please.
Yes.
So, talking about a non-operative management, like you said that, she was immobilized in a fixed ankle walker. How long she's been in a fixed ankle walker? How long it's been in, did we treat her non-operatively?
Yeah, you'd certainly want to give it a good course. You don't want to completely lock down someone's weight bearing for too long, but I think a few weeks of non-weight bearing and fixed ankle walker, and then progressing to weight bearing in that fixed ankle walker, and then custom orthotics can be challenging. What you learn as a practical matter is that they aren't covered by insurance plans unless the patient is diabetic, and they can be quite expensive. Also, right. Not all patients tolerate them. The UCBL that showed it, technically provides the support that will help the patient with the pes plano valgus deformity, but patients have issues tolerating that specific orthotic. So, in this case, by 6 or 8 weeks, kind of back in the office at the 6-week follow-up.
So, it's always an issue to me, how long you are going to treat them non-operatively. What do you think, Dr. Park or Dr. Cooper? Any ideas? How long you guys treat this non-operatively, with inserts or blocker?
Right. I'll usually do 6 weeks, and then if they're doing better, I'll initiate some physical therapy. And if they're doing much worse, or progressively worse, I would discuss surgery. I think sometimes an MRI can be helpful, especially in someone like this that is a little unusual just given her BMI. As James said, maybe the spring ligament is an issue.
Yeah, usually, heavier patients, we talk about a lot, especially in Dr. Park's clinic, the biomechanics of this. And simply put, it's not always easy to tell a patient, but the mechanics of having more body weight through the same size foot certainly plays a role in this. So.
What are you saying, James? They're larger than the average person?
This person is not. So maybe I chose an atypical patient with the atypical BMI for Central Virginia, but it's something like that. We find that in hips and even some knees, you know, they're really able to resist more force than you get from maybe a normal BMI person. But when you get down to the foot and ankle, you're putting potentially the stress of 5 times your body weight when you're walking or running, and so yeah, weight certainly plays a role in that. So she was indicated for operative intervention. Here are some intraoperative radiographs showing this medial displacement calcaneal osteotomy. So essentially, when you make this calcaneal osteotomy, you can slide it medially to address the valgus. You can slide it laterally, also in a patient with some varus, and you can distalize a little bit, which actually increases the, can increase that calcaneal pitch there. Now the bottom here, this is a view we'd like to get, a little challenging to get in the operating room, but the Harris heel view can show us that medial displacement there. So this is with a cannulated, partially threaded screw to get compression across there. You can also use newer options, include staples, which have a fixed step off, so we can use an 8, 10, 12 millimeter step off, depending on how much correction we want. You get pretty reliable healing of this osteotomy. There's a lot of surface area, well vascularized. So
how's that screw work, James? It looks like it's got 2 different pitches on that thread.
Oh, this is a specific type of screw that also has it's headless, but a tighter pitch or a shorter pitch on the threads here are going to affect the compression there. So
That's a cool screw design. The threads down on the end of the screw are actually wider apart, and so as each turn of the screw will actually compress that osteotomy site.
you get nice compression there. You know, a headed screw or a screw with a washer is a good option for compression, but kind of right down in the fat pad or right down in the heel weight bearing area. So the staples are also a good option that we use frequently. So that addresses the hindfoot valgus by doing the medial displacement. It's kind of interesting to think through, you know, with the heel. It's the same way where we would put the posting, kind of how we're changing the pull of the Achilles, the most strongest tendon in the body. A lot of force to correct the deformity if you change the vector of that force. Also then, when we talk about a lateral column lengthening, that's good for some patients. And it's usually putting a wedge in the lateral aspect of the calcaneus here. So you see this wedge opening it. So post-operative radiographs, this patient standing. So just grossly looking at it, you've got restoration, at least some degree of restoration of the medial arch there. This is 12-month follow-up. You've got nice healing of that osteotomy in the calcaneus. This patient also had posterior tibial tendon debridement, did not require augmentation. Overall doing well. So
That's gorgeous.
it's important if you just debride the tendon, but you don't correct the underlying biomechanical factors. You know, it's hard because if you know the cause, but you don't treat the underlying cause to the extent possible, then you're likely to have recurrence. So in this case, you know, the posterior tibial tendon continues to function, normal functioning foot and ankle, because you're correcting that pure biomechanical problem.
Hey, Dr. Park, how do you know how far over you slide the calcaneus?
That's a great question. I'll typically slide it, and then if I usually do at least 10 millimeters or so, depending on how bad the deformity is. But before, when I was using these types of screws, I would just pin it in place with the guide wire and then sort of check the hind foot compared to the patella in the long, sort of in the long axis of the leg. But I think that it's hard to overdo it, but so it depends on the size of the calcaneus. So a smaller person, you struggle to do more than, let's say, a centimeter in translation.
So Dr. Cooper, is this commonly, do you usually plan to do this on both sides, or is this usually unilateral, or how do you counsel those patients to have the same pulling to the side? I'm not sure you have a good, are you talking to a fax machine, Trent? Is it usually bilateral, Venkat? That's the beauty of hip scopes. Every person gets a hip scope, they usually have the opposite side too. James, I'll probably hold off on the second case, okay? We gotta get to Roanoke.
Yeah, sounds good.
So it depends upon, how bad is the other foot as well. Like usually it's a bilateral flat foot, most of the time if you correct one and they're happy with it, and then the way they walk is different, and they can, they can walk without pain and they can do stuff. Eventually they get the other foot done as well. So it's interesting because, in a younger age, it's usually like bilateral flat foot is more common. In an older age group where this obese patient, you can have unilateral, but most of the time if you have bilateral flexible flat foot, if you correct one, they're happy with it, there's no pain, they're able to do what they want to do, and eventually they get the other foot fixed as well.
Okay. Awesome stuff. Foot and ankle team, that was great. I do appreciate it. I think it's really important when we're looking at residency programs, having a broad experience ends up being critical for your overall training. And then be able to collaborate amongst different divisions. And I can tell you personally that Dr. Park, Perumal, and Cooper are just always so accessible to me when I have a foot and ankle problem with one of my athletes, or anybody for that matter. So Baris, are you out there? All right, my friend.
Yep.
So Dr. Cooper apologizes. His again, we got hit by tornadoes and lightning bolts. So Truett is sitting in his car right now to charge his phone.
Is my screen showing?
That was great. Yep.
Awesome. Hey everyone, my name is Baris. I'm a PGY-4 and I'll be talking about the Roanoke rotations we do throughout our residency. We do 4 10-week rotations, 2 as a 3rd year and 2 as a 4th year. I'm actually currently in the 4th year chief rotation right now. For those who aren't familiar with the area, Roanoke's about an hour and 45 minutes southwest of Charlottesville, has about 300,000 people in the metro area, and it's the largest city in Virginia west of Richmond. It's a 1,000-bed level 1 trauma center with over 30 orthopedic surgeons, and it's growing. They just hired 3 new orthopedic surgeons starting in the next few months, and they're still looking for more. Trauma is particularly busy here because we're right next to the busy Interstate 81 and cast a pretty wide net for traumas going into West Virginia and North Carolina. As far as the resident duties go here, we're in the OR every single day. We have a wide range of orthopedic subspecialties here with an emphasis on trauma. There are a lot of complex trauma cases with a busy trauma room or sometimes 2 rooms every day. And they just hired one of the recent former UVA residents who finished his trauma fellowship and will start here next month. Joint recon's also very busy down here. There's hand and upper extremity surgeons who do a lot of shoulder and elbow, others who do a lot of high complexity flap cases, brachial plexus surgery, congenital PTAN cases, very complex upper extremity cases here too. You can join the sports guys. They do a lot of elective surgeries as well. There's a couple of outpatient centers that are partially owned by Carilion Clinic that you can go to for those surgeries. We have 2 peds ortho surgeons here and just hired a 3rd one. There's also a lot of spine surgeries that happen here too. As for these photos go, the top right is one of the combo flap cases that Dr. Rapel does with the plastics team. And then the bottom right, he just always keeps his room dark and his headlight on. So that's sort of what that photo is about. And in the bottom left, that's one of Dr. Owen's famous Belgian anterior hip, total hip arthroplasties off the table. So you'll see a lot of that while you're here. For me, I've chosen to treat this block as like a trauma, shoulder, and elbow fellowship. I operate 5 days a week. I'm in the OR more than the fellows, and most of them I get to do start to finish with the attending acting like my assistant, which is really awesome. I just went through the past couple of weeks and I calculated about 20 cases per week, which comes out to about 800 cases over the 4 blocks you're here, which I think is pretty wild. There's a lot of fellowships that over a year you don't get to do 800 cases. Anyway, so we also take a lot of ED call, which is almost always second call, meaning you have another resident from either another program or another department in the hospital taking care of the first call, meaning so you rarely have to deal with like the minor inpatient like issues or patient phone calls and stuff like that. It makes you really focus on making decisions and doing procedures or reductions, which is awesome. We divide night call equally between the 4 residents, and the ED is slightly more capable here than in other places. So generally the consults are a bit more interesting and relevant. Essentially, Roanoke is where we refine our call skills. We have a lot more autonomy, and our decisions carry a lot more weight in the patient's care. On the other hand, if there's anything you haven't seen before or unsure how to treat, there's always an attending on call who are all really responsive and helpful too. And briefly, just to touch housing-wise, there's really no issues, nothing to really worry about. Every resident gets put up in his or own renovated 2-bedroom apartment, furniture, cable, fully stocked kitchen. There's a tennis court, pool, dog parks in the complex, 2 of the 4 pet-friendly in case you have any pets. It's all really well thought out by our program coordinator, so we really don't have to worry about that while we're here. As far as life in Roanoke goes, you're in the Shenandoah Valley and the Blue Ridge Mountains, so a lot of nature and hiking around, much like Charlottesville. That's my pups on the bottom left on the hike up to the Roanoke Star on top of Mill Mountain. That's Matt Deasy there, giving the old shaka bra. And then some of the residents, like Matt, they run and cycle with some of the group of the attendings down here every morning too. And it's just a lot of just hanging out after work with whoever's not in the hospital. We also have multiple labs each block where we get to play around with tools, sawbones, and implants. The staff here are really open and get a lot of funding to do as many labs as we want. Even in the current block, with everything going on, we've had 2 labs so far with appropriate safety precautions, as you can see there. The top one was a distal femur plating lab, and the right was a pelvic plate bending lab there. And we're still actually in the talks to get a couple more before the block's over. And then in the bottom left there, that's one of the chiefs playing around with the DePuy Kinsice broaching system, which if you haven't heard of before, it's like an automatic rifle going off as you're broaching the femur. And then briefly, just Crillon Clinic, like I mentioned, is growing rapidly. They're adding a $300 million expansion with more orthopedic surgeons hired every year. So, you know, there's a lot of surgeons who have been here for a long time. Some for over 30 years, and a lot of former UVA residents too. So I think it makes it clear that it leaves a good impression on the residents rotating through, I think. UVA ortho residents have played a large role in the orthopedic department here, and generally we have a pretty good reputation in the hospital, and I think we're treated really well here for that reason. And overall, I mean, for me, this actually played a pretty large decision for me to rank UVA first coming out of medical school. I mean, I went to medical school at UVA, so I think I knew about the rotation a little bit more than other people. But I think it was clear to me at the time from what I saw in the rotations and also from the residents at that time that the residents really come back from this rotation as significantly better and more capable orthopedic surgeons. So that's pretty much the long story short here.
Harris, that was awesome. Thanks. So the question from the crowd, do residents get to choose on which service they rotate or emphasize during their rotations, or how are they divided?
Yeah, it's not necessarily just like you're on a trauma rotation or you're on a hand and upper extremity rotation. All we really need to cover are the trauma cases, which is usually 1 or 2 residents a day. And then the other 2 or 3 residents get to sort of choose depending on what is going on in the OR. Like I choose to go to the hand and upper extremity cases. You know, Emmanuel does a bit more joints because he's going into joints. But you know, it's a pretty mix of things. It's not necessarily one rotation or one service.
Emmanuel, this is your 3rd time around. What has been your experience in Roanoke? You're muted. Emmanuel, you're muted.
Yeah, there we go. It's great. Third time around is fantastic. Baris is responsible for the schedule right now, so I don't have to worry about that. But as a 4 now coming back, we kind of get the first choice in terms of what we like to cover, and there's certain attendings that have certain needs of residents, so they put in a request, or they request a resident, and then the residents kind of get distributed, and it works out great because Baris likes all the upper extremity stuff. And for me, I like more lower extremity stuff. So we can do that. And then there's so much work left for all the 3s and everyone else that it's really a great operative experience. I think there is a question in the chat here if the first Roanoke rotation is mostly in the OR or predominantly in the ED. So the way it works is usually that we are on call, which means one resident is on first call, somebody else is on second call, and the first call resident pretty much gets all the pages, all the floor pages and all the ED consult pages, and you manage, or you're in the operating room while dealing with all this other stuff. So you don't just spend time in the emergency department or on the floor, you're in the operating room, and in between cases you take care of the consults or anything else that you have to.
Yeah, you get pretty efficient during your second year dealing by making decisions. So, you know, you're really, you're in the OR, you're getting an operative experience, and then, you know, in between cases, you staff consults, or like whoever's on first call, they tell you about what's going on, and you sort of, you know, you're just making decisions or helping with a reduction, and then you get back to your next case. I mean, it's really, that's what that rotation's about.
Yeah, and when you come to Roanoke and you are the second call person, there's nobody else that you talk to. In terms of there are no upper level residents, you know, I mean, yes, we are all available and we talk to each other, but it kind of forces you to think about that consult and not just think about what has to get done immediately, but also then think about the surgical plans the next day. How are you going to arrange the cases so they make sense, and how are you going to be efficient with everything? So yeah, it's a great experience. You mature a lot, and you learn a lot. Yeah.
Hey, Tim. Can you unmute yourself?
Yep.
What was your first night on call on Roanoke like? So Tim's one of our PGY-3s. This is his first block on Roanoke, and he just got done with PGY-2. What was your first night like, Tim?
Yeah, my first night on was probably the busiest one I've had, actually. I think we had 18 consults over 24 hours, and 12 of them were overnight. So it was a busy one, but it definitely makes you efficient. And I think a couple things that were mentioned. One is that every day you're here, you're assigned to an OR. So that definitely comes first. And the nice thing about call here, like second call has been mentioned, it's definitely for the third years, it's the first time we're in that sort of chief role when it comes to consults. You got someone else going and seeing the consult and then reporting back to you. So you kind of have to prioritize and think about the consult differently. And I definitely started thinking about next steps, like when I'm seeing a consult, thinking about what I want to post it for, what's the case order going to be, what equipment are going to be, what are we going to need, and what bed and all that. So it kind of makes you think about the next steps, because you're going to be the one explaining why you chose that, and then you're going to be the one doing the case potentially. So busy, but it kind of helps you think about the next steps.
So what are some of the logistical differences between UVA and Roanoke you've seen so far, Tim? Like how do you get a patient from the ER to the OR? Is it more or less efficient than UVA?
It's more efficient, I would say. And it's good to get a view of how a different hospital system works, but it's a little bit more on you, because if you say a patient needs to go to the OR, then they're going to go to the OR, and it can happen pretty quickly. So you just go upstairs, tell the OR that you need to post a case, and they're like, okay, well, you can bring them up. So you just go back to the ED again and bring them up.
Yeah, you don't have to, like, you know, call anesthesia, call 1311. It's so you don't have to have that you communication with anesthesia where you talk to the residents, so the residents have to go talk to the attending. You just post a case. You don't even have to put in an order in Epic, and it's just done. Like you just talk to one person, say it's a hip nail, and it's taken care of, and the process starts.
And anesthesia also doesn't cancel a lot of cases because there are no residents over there. It's only anesthesia attending and CRNA. So if there's no type and screen, and if the blood hemoglobin is, you know, 5 or 4, they don't care. They just transfuse right there in the OR. They block in the operating room. So yeah, if you tell them you have to go to the operating room, they go and they're quick. So you have to know what you're doing. Yeah.
I found that to be the case. I mean, I was a resident at UVA and went to Roanoke as well, and I found there were a lot of things about Roanoke that were very appealing. So, two of you, I know Baris and Emmanuel, you both are married. What is it like having a wife or a family when you go to Roanoke? Is the balance hard, or how would you guys address that?
No, I don't think so. I mean, you get every other weekend off essentially. We split the weekends, and I mean, I go back pretty frequently. I think I see my wife just as much as I would at like at UVA. Really, I mean, it's I only see her for like 2-3 hours at a time anyway at night. And, she's a picky fellow, so
Yeah.
I don't think it's a whole lot different, honestly.
Yeah, I second that. My wife is also in medicine, so I see her as much now as I do.
What's the fastest you ever gotten home, Emmanuel, from Roanoke?
I don't think it's legal to say. No, it's always the same. It's pretty standard. It's a 2-hour drive. It's very simple.
Hour 45.
That's awesome. Well, yeah, I mean, I think that, I think UVA, when you're looking at UVA from the outside, you see that we go 2 hours away for 40 weeks out of your rotations. It seems like it might be a detractor, but I don't think exactly the opposite. My experience in Roanoke was awesome. And as a faculty, and I think that I can speak for Keith and the other faculty you're on, Trey's on here too, Venkat's on here. It's tangible, the difference between a resident before and after they go to Roanoke. They have this new level of confidence when they come back. That as a faculty, it's really kind of cool to see that. And I just think it's nice to have two different perspectives on how you do things. UVA is ultra academic. We have a lot of faculty are subspecialized, and there's a ton of residents here. Roanoke is more private-demic, almost private practice type, and so it gives you a really broad picture of what kind of practices are out there. And then you get 30 new faculty you can mentor with. Tim, that person on call, who are you on call with?
Yeah, so first call is either an ED resident, a Roanoke ED resident, or a podiatry resident typically. Sometimes it's a second-year ortho resident from Florida. So it depends. You get experience working with an ortho resident who might be experienced to consults and they know what they're doing, versus an ED resident who has no idea how to treat ortho problems. I don't know. At least for me, it's been really helpful in learning how to teach people how to see consults and how to splint, how to do basic orthopedics. So can be challenging to teach someone who's never done it.
Yeah.
You get a pretty wide variety of first call residents.
And Baris, maybe you can speak to this a little bit, but like you're talking about like kind of making your rotations the way you want it. How do you just choose to do upper extremity stuff? I don't understand. Like
You just do. You only need to cover trauma cases, which is 1 or 2 rooms a day, and then if there's all the attendings and the PAs, all the attendings and the staff in the OR are used to not having residents. So if you show up, that's great. They have one more person to help out, and really you actually get to do a lot of the case. It's not like they don't expect you in the OR, but when you show up, it's awesome. So it's the OR runs pretty efficiently, and you get to do whatever you want to do in the OR.
Awesome. That's really great, guys. So are there
Winston, I was just going to say, this is Joe Park. I'm one of the foot and ankle guys. When I did residency at NYU, and we used to rotate at shock trauma for 3 months in Baltimore. And, I spent, I saw the most complex trauma that I've ever seen. And I'll tell you that it really makes you appreciate, how things can be done efficiently. And, in an academic center, it's not always the same way. So, I would also see 15, 20 consults a night, and of which, 13 of them were operative for the next day. So it really changes how you manage these patients. And someday, no matter what specialty you do, you're going to be on call and you're going to have to know how to do this stuff. And I think doing it 4 times is definitely better than just for me going for 3 months, only because, you only get to meet the attendings that one time and it's hard to gain their trust. Whereas I think these guys all get such great relationships with the Roanoke attendings.
Yeah, I would echo that. A question from the crowd. Do you take hand and spine call while you're there, or is that split with somebody?
So no spine call. Neurosurgery does all the spine call. And then hand call is split with plastic surgery, yeah. It used to be less, but this year they're actually making it 50-50 with plastics.
Yeah, like 75-25.
Oh no, like this, like as of this, like this month, they're actually changing it.
You're bringing the hammer down, Baris Chief. I like that.
So
As somebody with 2 kids, and you know, who same story as Baris, you know, this is where I wanted to be. This is my number 1, and Roanoke was the thing I was most worried about. And I can say, haven't been down there twice. I absolutely love the rotation. Like Baris said, you're off every other weekend. When you're there, you really get to focus on work. Obviously, family can come down and visit. My daughter loves, they're like closets in the bedrooms down there that seem like mini rooms. So you get like it's like a 4-bedroom for a 5-year-old. So I would say it's a ton of fun, and I was pleasantly surprised that Roanoke was an amazing experience. And as much as I love Charlottesville, I do look forward to rotations down there, even loving my wife and both my children and my dog.
I never threw away your daughter's drawings, DZ, after you left.
Oh, they're still in there? Thank you. Is Dennis's hair still in one of the drawers?
I threw that away.
Thank you.
That was Matt DC talking for everybody who didn't identify himself. But yeah, Matt has 2 kids and a wife, and so it is when you have a family, it does weigh on you about leaving for that period of time, and it might sound insensitive, but sometimes it's kind of nice to be. You go down there and pretty much all you're doing is ortho 24/7. And for me, I mean, I think I got a lot more studying done, a lot more research done when I was down there, because basically I lived and ate and breathed orthopedics, and then, you know, the sawbone stuff, and it was just a lot of fun being down there. All right, guys. Well, it's 8:57. So if there's another question, do you want to do some spine call down there, Baris? Is that what you're saying? I think James wants to do some.
I love it just the way it is.
I can arrange
Only the spine pus for me.
Oh, spine plus. I see. Awesome. Well, that was really, I think, really helpful. It's already 8:57, so Keith and I will try another time to meet with everybody, but I think we can probably conclude this session. So Dr. Bachman and myself want to catch up with each of you guys individually, everybody who's kind of rotating here virtually, for 10 to 15 minutes. And so I'm going to send out a Google document for you to sign up to chat with us, if that's okay. Probably might not be next week, but the following week. I also wanted to say that that if you guys want to come to our lectures in the morning, I haven't necessarily put you guys, I don't want you guys to feel like, you have to log into our lectures in the morning, but if you guys want to have exposure to what we do in the morning, I'm happy to put you guys on the conference list, and you can log into our lectures. They're all virtual right now anyway, so that might be kind of cool. And finally, we are going to have virtual interviews probably in January, and I'll have more information later in this session about that as well. So next week's going to be spine. It's going to be standing room only, I'm sure. But our spine team is awesome. They're going to have a lot of cases to go through as well. And I think we're talking about mentorship next week too. One of our residents will be talking about that. So it's going to be talking about life outside the hospital. So that'll be kind of fun, Thomas Moran. So again, we also have a YouTube channel. So I'll put this recording on the YouTube channel if you want to come back and review it. But otherwise, keep in touch and keep emailing me and reaching out to me if you have any other questions about the program. But Venkat, Baris, Emmanuel, Tim, Matt, Joe, everyone out there, thank you so much for all your stuff here. I really do appreciate it. It's a lot of fun.
Yeah, absolutely.
Thanks, Vincent.
All right, guys. Have a good night,
Thank
okay?
you. Thank you.
We miss you guys.
I miss you too, Matt. You're my boy, Blue.
You were what?